Hello and welcome to Bite-Sized MRCP, a manageable way to digest the things that you need to know for your MRCP exam. We are two junior doctors based in the UK who have passed all three parts of the MRCP within the last 5 years and want to help you do the same. We're not associated with any MRCP examination organizations, and the materials covered are by no means an exhaustive list of what can come up in your exam, and indeed are not intended to be used as medical advice. Please refer to your College of Entry or your friendly supervisor for further questions regarding the exam and syllabus. If you like the sound of what you hear today and would like to join us for more bite-sized revision, give us a thumbs up and press the subscribe button. Now, without further ado, let's get into today's topic, which is on anaphylaxis under the section of Immunology. What is anaphylaxis? It's an IgE-mediated mast cell degranulation inducing release of histamines. And clinically, it has one or more of the followings: A, laryngeal edema, B, bronchial obstruction, and C, hypotension. It's really important to differentiate this with anaphylactoid reaction, which is a non-IgE mediated mast cell degranulation. But otherwise, it can clinically present in a really similar fashion to anaphylaxis. The epidemiology of anaphylaxis is relatively common. It affects about 1 in 10,000 annually. The common culprits are foods, drugs, latex, and venoms. I'm sure you're all familiar with the signs and symptoms of anaphylaxis, as this is something that is one of the core components that is covered in medical school curriculum. However, just as a recap, you would be encountering a patient who is wheezy that could have also associated stridor due to the upper airway closure and edema. Patient will have facial, tongue, and or throat swelling as a result of angioedema, and they frequently describe this feeling of impending doom. If your blood pressure is low enough, you could get syncope as a result of your hypotension. And classically, for a true anaphylaxis reaction, you would need some urticaria rash, which is what some people commonly describe as hives, which are classically itchy and are associated normally after ingestion of one of those common culprits that we discussed earlier. The investigations of anaphylaxis really is to try to find a culprit. And that is to say that having a detailed history once a patient is stabilized, especially of foods and drugs, is really crucial. Very frequently, you're expected to do mast cell tryptase within 6 hours of ingestion or having the symptoms of anaphylaxis. And this is something that is routinely done on the acute medical units in the hospitals. Then later on, you would frequently be testing the patient for skin prick testing to try to come and identify the potential culprits, and also total immunoglobulin E levels in the blood would be helpful, as this is typically raised in cases of true anaphylaxis. So the management of anaphylaxis really is something that I'm sure you're all familiar with, as it is a medical emergency. The management would be through the ALS algorithm, which is the Advanced Life Support algorithm, and that is with an ABCDE assessment. The drug of choice, of course, is adrenaline or EpiPen, and the dose is 500 microgram intramuscular in adults, 1 in 1,000 dilution, and you may need to have repeated doses if the symptoms are not resolved. It would be important to identify the culprit and remove it immediately. So, for instance, if the patient is attached to an intravenous antibiotic and that antibiotic is still running, then it will be really important to discontinue the medication in order to stop the offending agent. You will, of course, be managing the breathing and circulation with oxygen and appropriate intravenous fluid that is normally given as a stat or bolus. And in terms of managing the symptoms, antihistamine corticosteroids are frequently co-prescribed. It's really important that patients are educated about this potentially life-threatening allergy, and their record is also updated on the hospital systems. And to make everyone aware, it's important that the patient wear a medical bracelet. And later on, as part of the education, they would be provided normally with an EpiPen in the form of long term, and they should normally be carrying 2 at all times with them once they are discharged. So let's do some questions. Which of the following statements is correct? A. Anaphylactoid reactions are IgE-mediated reactions. B. In a suspected case of an adult with anaphylaxis, the required dose of adrenaline is 500 microgram of 1 in 10,000 dilution. C. Measurement of mast cell tryptase is helpful to differentiate between an anaphylaxis and an anaphylactoid reaction. D. Anaphylaxis in patients on beta blockers may be refractory to adrenaline. E. Patients can be discharged from the acute medical take as soon as they are stabilized after receiving adrenaline for anaphylaxis. So if you want to pause the video and have a think about your option, we are going to go through it now. So the correct option is option D. So we will go through all of them one by one. Anaphylactoid reactions are non-IgE mediated. This is something that we discussed in one of the beginning slides if you were paying attention. Option B, the dilution of the adrenaline is incorrect. The correct option would be 500 microgram of 1 in 1,000 in the case of an adult anaphylaxis. Option C, it's incorrect because mast cell tryptase is actually not helpful between differentiating an anaphylaxis and an anaphylactoid reaction. Option E is also incorrect because stabilizing the patient is one thing. However, it's really important to admit the patient after they are stabilized in order for them to be monitored for at least about 12 to 24 hours in case of a recurrent or a delayed reaction. And option D, therefore, is the correct option. And that is true that if the patient has been on large doses of beta blocker for long term, they may be refractory to adrenaline. And in those circumstances, it's really important to inform your intensive care colleagues or critical care colleagues for consideration of the patient for level 2 or level 3 care. Thanks for listening to this episode of Bite Size MRCP. If you like what you heard today, give us a thumbs up and hit the like and subscribe button to make sure that you don't miss out on our next episode. Let us know in the comments which topics you would like to hear in the future. See you in the next episode.